Good day and welcome to our webinar. Today's topic is pain management in dementia care, and we have two excellent speakers from Silverado Senior Living. I'll tell you about them in just a few minutes, but first I want to thank our sponsors. They are Care Choices, Hospice and Palliative Services, O'Connor Mortuary, Caring Companions at Home, and Alzheimer's Orange County. And I'm Kim Bailey, and I'm with Alzheimer's Orange County. Our sponsors are wonderful, and they provide these services, these webinars on a monthly basis to you as a service to the community on topics that are beneficial for anyone who is working in the field, caring for older adults, and any family members who are caregiving. So I think that today we'll find this topic especially helpful. And our speakers are Erin Light and Kim Buttram from Silverado Senior Living. It's time for me to introduce our wonderful speakers. So we have returning to us a very popular speaker, Erin Palpozzi. She is the senior administrator at Silverado Senior Living in San Juan Capistrano. She's a gerontologist with 10 years of experience specializing in dementia care and supporting the needs of older adults. She received her bachelor's degree in cognitive science from UC San Diego, after which she worked in dementia research in a joint UCSD Veterans Hospital venture, researching mild cognitive impairment in older veterans. Erin obtained her master's degree in gerontology from USC and became the graduate researcher on a joint Silverado Senior Living USC study, which was exploring the effects of daylight in reducing depression in memory-impaired adults. Erin also holds a residential care for the elderly administrator certification and a dementia care specialist certification. She's also an active member of Vance Cesar's leadership development program. Erin's passion for older adults experiencing memory loss stems from supporting a grandparent with dementia in a caregiver role during her adolescent years. Erin has extensive experience hosting support groups for various populations, including family members of individuals with memory decline. She also participates in speaking engagements on executive functioning and cognition. Erin is the advisor to all the master's level social workers employed at Silverado memory care communities nationwide, and hosts a company-wide Zoom support group for the general public. So we're delighted to have Erin back with us, but joining her today is Kim Buttram. Kim joined Silverado in 2014, bringing 30 years of extensive experience, leadership, and clinical expertise in serving and treating those with neurodegenerative disorders. As part of her role, Kim oversees Silverado University affiliations, as well as any of the studies in which the company participates. With a strong background in Alzheimer's and dementia research, Kim is committed to harnessing the clinical expertise at Silverado to ensure that results from the latest studies are put into practice. Kim also works with the nursing teams to analyze and develop best practices based on Silverado's evidence-based clinical outcomes, which have been collected over their 25-year history. Kim holds a BSN from Loma Linda and a MSN from Boston University. She has worked in a variety of settings, including long-term care, rehab, home health / hospice, and academic research. She served as leader of the multidisciplinary team at UC San Diego's Alzheimer's Disease Research Center clinical arm and at the Memory Center at the University of Texas Austin Neurology Program. So we have two eminently qualified presenters to talk to us about a really critical topic, and I'm going to go ahead and turn it over to our speakers at this time. Thank you for being here, Erin and Kim.
Thank you, Kim, and Alzheimer's Orange County. It's always a pleasure to work with you and to present on this really important topic today. We're going to jump right in, actually, and a lot of this presentation is going to be reviewing how we understand behaviors with respect to individuals living with dementia and also living with pain. Behavioral and psychological symptoms of dementia should be seen as a communication of an unmet need, which needs evaluation before the symptom is treated away. And that need should be assumed to be discomfort or suffering before anything else. Pain might get overlooked, or it might be confused for a psychological issue. And we'll get to that later in the discussion. So real quickly, some of the definitions for pain and suffering. Pain is more of the physical discomfort caused by an illness or an injury. It could be sudden, it could be chronic. It also includes mental distress caused by emotional states such as fear, grief, or depression. Suffering, on the other hand, is more of the general umbrella of the state of experiencing pain and distress, struggle, or hardship, and it often has a lot of multiple layers and unfortunately is a lot of times ongoing. So where does pain come from most commonly in older adults? So here's some of the sources here. And we'll start with physical pain. We have medical procedures, mechanical or postural issues, arthritis, immobility, injury, could be from pressure sores, infection, and even cancer. Mental suffering, likewise, could be from bereavement or loneliness, depression, anxiety, feeling lost. Memories could be from PTSD as well, delusions, hallucinations, changes to care, and staff rotations. And I just want to make mention that whether it's physical, psychological, or even perceived pain, it can last decades. So just as we age, it doesn't mean it's going to go away. There's a really strong correlation between pain and aggression. So the Shelter study from 2012 across 2,822 cognitively impaired patients in Europe showed that pain was significantly and positively associated with resistance to care, socially inappropriate behavior, so those are both physical, and then the abnormal thought process and delusions, which is alongside the psychological distress. A quick example of this that I often share when we're training some staff. This is very logical to show an expression of pain. So if I'm an older adult and I have cognitive impairment and I can't express myself very well, let's say I'm sitting in a wheelchair and you're a caregiver and you're going to come and assist me. Well, you've been trained well. You're going to come under both of my arms. You're going to help me up so as not to cause any damage. But I have really bad shoulder pain. So because I can't verbalize as well that it's going to hurt if you touch me, I'm going to push away. So sometimes that push can be seen as aggression, for example, when really it's just an old shoulder injury that we might be able to resolve quickly. Okay, so identifying the cause of discomfort. Pain doesn't necessarily have to be severe. People living with dementia often suffer from general discomfort from a variety of causes, such as osteoarthritis, from lying in a hospital bed too long, or sitting in a wheelchair too long. Sometimes when we're having caregiver meetings, I ask a caregiver or two to sit in a wheelchair that doesn't have a cushion in it for a little while, right? So we want to see how that feels, because at any decade, that's not comfortable. And so it's really important for us to be transferring our residents during the day or at home if you're a caregiver as well. And due to the dementia, they can have difficulty in correctly identifying their discomfort and then being able to communicate it. I worked with a gentleman who had sporadic pain in his sciatica. And he was also a veteran from a war. And every time his sciatica would flare up, he would look around him because he thought somebody was hurting him. He thought somebody around him was the cause for that pain, right? So that type of confusion with the dementia, the paranoia, the delusions as well, can really go hand in hand with this. Chronic pain in the elderly. So those living with dementia, they're often living with other potentially painful chronic diseases, such as the most common ones, of course, heart disease. We've got back pain here, cancer, diabetes, asthma, COPD, arthritis, just to name a few. And chronic pain in the elderly, the prevalence of pain is estimated to be 3 times higher in older adults. Studies consistently demonstrate that 25 to 50% of older adults have persistent pain and regularly take analgesic medication, and that's pain relieving medication. In chronic pain, the autonomic system adapts and the person may not exhibit objective signs of pain. So the autonomic system, I always think of it as what happens automatically, right? It includes breathing, respiration, digestion, heart rate, blood pressure. So things that are automatic, that's part of the autonomic system, right? So blood pressure, it might be elevated a bit for pain, but that just could be normal in somebody who's older and may have a history of high blood pressure, right? So it might get masked. It's really important for us as healthcare providers to ask about chronic pain. So at Silverado, for example, when we have a new family coming in, we're asking them really detailed questions. Have they had surgeries? Have they had any incidents across their lifespan? It could be, we had a gentleman who fell off his roof in 1995, let's say, and broke a lot of the bones on the left side of his body, and his left shoulder was never the same since, but he never complained about it to the family after he got dementia. All right, so we hear those tendencies of very well-meaning issues, but they can be long-lasting for sure. All right, so unfortunately, pain is very undertreated in those living with dementia, and this is a few of the studies. For example, on the left, the Canadian study showed that although almost half of cognitively intact long-term care residents had scheduled pain medication orders, only 25% of seniors in general with cognitive impairment have such orders, right? So obviously, if you're being overseen by somebody on a daily basis, they're going to notice a little bit more. So if they're living at home, it's really important to take them in to have an assessment once in a while for this. In lieu of that, as well, for patients with hip fractures, right? Advanced dementia patients received a third of the amount of morphine as matched cognitively intact patients. So this is really sad to hear. It could just be because they weren't able to express it, or maybe it was mistaken as something else, right? So if you have somebody who you're caring for with a hip fracture, you know, it's our opportunity to be their advocates. All right, we're going to take a look at some of the behaviors that generally respond to pain treatment, right? So something routine. Here's a few: resistance to care, repetitive sentences and questions, complaining, being negative, constant requests for attention, cursing, verbal aggression, restlessness, right? So back pain, kind of shuffling a little bit, and pacing. I'll share a story. We had a gentleman, he was a policeman by trade at one of our communities, very tall man, very kind-hearted, but just really didn't do great during dining hours. He was very aggressive. Sometimes he would get up and pace, and could have easily thought, oh, maybe it's just overstimulation. He doesn't like who he's sitting with. Maybe it's just not what he's used to, misses his spouse, for example. But we're sleuths at a lot of healthcare providers, just like Silverado is, and we were able to discover, one of the nurses discovered he had a cracked tooth, right? So the toothache that only flared up during dining, right? So we were able to resolve that, and then he was able to go back to that. But had we not looked into it further, that could have been something that was qualified as a behavior. It could have had added medications, maybe for anxiety or some psych meds, right? So yes, the disease process is a difficult journey, but my motto is, if they're in distress, we need to address, right? So it could be a toenail that's broken. Maybe that's the reason why somebody's pacing, for example. Okay, so this is one of my favorites to review, nonverbal cues, right? So common expressions. We want to look for these. Slight frowns, right? So a sad or frightened face, grimacing, wrinkled forehead, closed or tightened eyes, rapid blinking. They could be sighing or moaning, maybe, grunting, chanting, calling out, asking for help. If you have somebody who keeps saying, help, 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 and you go over and ask them, what do you need help with? Nothing, right? It could be a pain response, right? Rigid or tense body posture, guarding, right? Guarding that shoulder, like that example I shared. and then increase pacing and walking as well. Another thing we also train our staff to is which war, if there is a veteran, right? So somebody who was in the Korean versus the Vietnam War, we're going to be looking for different symptoms. We might be looking for lung issues versus knee issues, right? So that's also very important. And signs of pain, even if it's passive, just sitting all day, simply sitting all day, watching some TV is still going to get you some stiff joints, right? All right. So some of the changes and the habits and the patterns that you're going to see if somebody is experiencing pain on that long-term or short-term scale would be the following: aggressiveness, combative, resisting care, decreased social interactions, socially inappropriate or disruptive or withdrawn, refusing food and appetite changes, sleep and rest pattern changes, changes in activity, social interactions, changes in gait and mobility. And so it doesn't really, irregardless of what decade you are from and when you were born, if you pull a muscle at the gym or playing sports or just getting out of bed wrong, it's going to hurt for a couple of days, if not up to a week or more, right? So even as we age, simple things like that, a simple backache, could really put us out of sorts. So if you just remember the last time that happened and how much it threw off your whole entire day, and then add cognitive impairment on top of that. And this is what we see. Okay, so some of the verbalizations of pain may sound like help, help, or I want to die, or get out, or move away, right? So some individuals with dementia, if they have difficulty expressing themselves, which we call word salad, sometimes it's okay for us to try and gesture at certain parts of their body with a look of concern while saying, does it hurt here? Is your arm in pain? Does it ache? Right? We train to this. If you're a nurse, you've heard, you probably do range of motion on somebody where you help them do some passive movement to see if there's any withdrawing or any of those nonverbal cues that we mentioned earlier. So if we had known how painful it is, right, the data to date suggests that even though people have lost the ability to communicate, they still have pain and suffering. And it's usually due to a comorbidity or new diseases. Medical interventions, something as simple as a blood test, right? We just went through COVID, taking somebody to get a shot for the vaccine, or having a clinic come to a community to give shots. Sometimes it didn't go too well, right? So that could be misunderstood. They don't know why they're getting a shot. Why is my arm hurting? What did you do to me? I'm going to get up and walk away at the very least. So some painful health conditions that may go unnoticed. Mouth issues, we mentioned that earlier. So the sore gums or gum disease is very painful. Individuals experience cognitive impairment may have difficulty maintaining good oral health, right? Might not want to brush their teeth, might not brush both sides, might clench their teeth together when we're trying to assist them with brushing our teeth. They may have a loose tooth or a cavity. Arthritis, so if we're looking for swelling or redness or stiffness in our extremities, especially in the hands and the feet, our limbs, the neck and the spine. Constipation is another big one, right? Sometimes brought on by medication, sometimes just affected by reduced mobility, changes to diet, inactivity, reduced fluid intake. Could be something as easy as the amount of vitamins, right? So it just depends on how the body's processing. Urinary tract infections or UTI, if you've had one of these, you know how painful they are. Even when we get antibiotics on board, it still takes a couple days for the pain relief component to kick in. So they might need something in the meantime if they're going through this. It's still going to be very uncomfortable for a little bit. Ingrown toenails and feet issues, and then immobility, sitting too long in one place, especially in a wheelchair. Some of the non-drug approaches that may reduce discomfort, and these are not a replacement, of course. Temperature, so having a warm pack can help ease aches and stiffness, whereas a cold pack could help reduce inflammation. Massage therapy is another one. A lot of communities, including Silverado, bring in a massage therapist. It's not just for relaxation and anxiety reduction. It could be for edema, which is also very painful, and also for stiff joints. Other relaxation techniques, such as music therapy, aromatherapy, essential oils, pet therapy as well. These, again, they're not designed to take the place of medications, but they can ease a little bit of the discomfort and bring us to a little bit more of a calmer state to be able to process. All right, so we want to make sure we're using gentle methods when communicating with somebody who's experiencing pain and dementia at the same time. So they're still going to be able to read our body language and facial expressions very well. So we want to remain calm. We want to approach them from the front and speak in a slow, soft, comforting voice, giving them a little extra time to respond. Of course, as always, physical restraint is never an option. This can cause ambulation issues, weakness, poor circulation, incontinence, and just overall poor quality of life. So non-stressful gestures we can use could be offering open palms. Making sure we're sitting eye to eye at the same level of the individual is really important. And we want to mimic facial expressions as well to let them know that we're understanding as much as we can what's going on and helps them feel more important in the moment, right? We don't want to distract them with a snack. It's very kind-hearted, right? Like, oh, I'm sorry, seems like you're having a rough day, Mrs. Smith. Let's go get some ice cream. I know you like chocolate, right? Very kind-hearted. It's a wonderful gesture. However, we're asking them to overlook and push through pain, which is what we don't want to have them do. And to explore that a little bit more, reducing the assumption that somebody can push through pain, I always like to go over this with families and care staff as well. So you've probably seen this in some form or another, Maslow's hierarchy of needs. So if you notice on the very bottom in the green, physiological, right? So this is your first need that you need to meet, and then safety is next, and then love and belonging, and so on and so forth. So health, the need for air, food, water, and health is at the very bottom. Health includes pain, right? So if you're experiencing example one, you have a toothache, and your friends are asking you to go to dinner and a movie, the friend piece is up in the need for love and belonging and inclusion, right? So how likely are you to socialize if we haven't met our basic baseline? Additionally, another example, if you're experiencing a migraine and you need to attend a family reunion, how likely are you to socialize then, right? Those are extremely painful. You could already be at a family dinner and your back hurts. So how likely are you to stay in your seat, right? So we just have to keep that in mind. A lot of memory cares. We have a lot of engagements. We have a lot of processes. The environment is really rich and built to support all aspects. But if you're looking for the socialization piece and your loved one has some pain, it's really important for our care staff to make sure to address the pain first, right? We can't have them overlook what's going on internally. And oftentimes it's really important just wherever someone's at right now, a little sluggish or having a little bit of discomfort, always check for a UTI. It's very common. Even 2% of dehydration in older adults leads to confusion and delusion. So this is really something that we can do to aid any discomfort, even right away. Right. So general population health studies on common comorbidities, like we've discussed, such as the following, they show this: osteoarthritis, for example. Over 55% of those over the age of 65 reported having pain, aching, or stiffness in a joint on most days. That's a lot. That's not a great quality of life. With diabetes, after 2 years, 26.4% have peripheral neuropathy, right? And that's nerve damage, especially in the hands and feet, which is very painful. And also Parkinson's disease, Lewy body disease. Muscle cramps are very common, and pain is the most common non-motor symptom in Parkinson's and Lewy body diseases. So it's important to be on the lookout for that. So pain and behavior management. Out of 16 randomized clinical trials show that pain and behavior affect each other, and we've looked at some of the examples of that. A formal pain assessment, as I mentioned, can improve pain management. And this is because physicians miss 24% of pain that's detected by an assessment, right? You take your mom or dad or your spouse to the doctor. How's everything going? Oh, it's fine, right? Oh, you look good, still driving. Yeah, okay. Kind of just move on with your day, right? It could be very slight cognitive impairment. So we're kind of missing quite a bit. So those pain assessments that are done by physicians can help tremendously. 60 to 80% of people with dementia in care homes regularly experience pain, most commonly from musculoskeletal or gastrointestinal issues and cardiac conditions, right? So urinary tract infections or pressure ulcers. If you're thinking of this and you're listening thinking, oh my goodness, I have a loved one who's in pain and I think I missed it, right? Do not panic. This is a great opportunity to consult with your general physician for them. This is really difficult to detect in general, and so that's why these type of presentations are very important for to detect situational events. All right, we're going to spend a few moments on end of life experience. In the 18 months before death, individuals with dementia experience, the first one's difficulty breathing. So 46% experience that more than 5 days a month. Almost 40% experience pain more than 5 days a month. And that's probably on the low end. Almost 40% experience pressure ulcers. Over 50% experience agitation. And 40% experience aspiration. This next quote here is really important. The frequency and pattern of suffering in individuals experiencing dementia are similar to those in patients with terminal cancer. All right, so I'm going to say that one more time. Frequency and pattern of suffering in individuals experiencing dementia are similar to those in patients with terminal cancer. And unfortunately, I'm sure a lot of us have had or know somebody who's been through cancer. It's extremely painful. And so that level of sadness and heart-wrenching, that's what we want to make sure we're attributing as well to this. End of life agitation. Some of you may have heard this term already, terminal agitation. Sometimes as we age, we slow down a little bit. Terminal agitation, unfortunately, it describes a type of behavior that's very anxious and restless and unsettled. It could be linked to emotional, physical, or spiritual distress. It basically means agitation that occurs in the last few days of life, but it can be present in the last few weeks of somebody's life, especially if they're experiencing cognitive impairment. You might also hear terminal agitation being described as terminal restlessness, terminal anguish, confusion at the end of life, or terminal delirium. They all have different meanings, but they do overlap. And agitation is often a symptom of delirium, but some patients can become agitated without delirium. Now, keep in mind, this is not an inevitable part of the dying process. If an individual is agitated at the end of life, it's important for us to try and manage it. So what does it look like? It looks like the following. It may present as confusion, not being able to get settled or just having distressed behavior, calling out, moaning, shouting, or screaming, hallucinations. A lot of this sounds like pain, right? Trying to get out of bed or wandering or pacing, being sleepy during the day and active at night, harder to rouse from sleep, unable to concentrate, rambling conversation, a lot of strong facial cues like frowning, grimacing, looking less peaceful, fidgeting included, repeating, picking at clothes or bed sheets. And the agitation can come on suddenly or gradually, and oftentimes it does come and go. It may stem from these physical or psychological factors, such as urinary retention, right? So if somebody has a catheter and they're unable to void or they're just having trouble with that in general, that can be very painful. Organ failure as well, infection, sepsis, a brain tumor, oxygen deficiency, Could also be from emotional or spiritual distress, right? This is still real pain that somebody's experiencing. Pre-existing mental disorders, changes to blood levels, and sometimes a drug withdrawal like nicotine, adverse medication reactions. So what can we do to help support them? We want to try and find out what is soothing to them. It could be music. The music from the ages, music we heard from ages 12 to 25 is the most impactful and the most memorable. So trying to find out what that is for your loved one is really helpful. Holding their hands, right? So sometimes if we're unable to communicate, just holding their hands, maybe gently rubbing their back if that's something they're comfortable with. We just want to provide a calm and safe environment that includes memorable items for them, that things that are known, right? A picture, a clock, photos, maybe a blanket. And then when we are assessing somebody with agitation, it's important to rule out if there's any changes in medication recently. Maybe something has changed in the environment. Simple one, do they need to use the restroom or are they constipated? We want to rule that out pretty quickly first. That's a pretty easy one for us to figure out. Do they have uncontrolled pain like nausea, which should be addressed immediately at the ER? And then are there any signs of alcohol abuse or substance withdrawal?
And what we wanted to share now are several success stories that we've had at Silverado. And let us just say that we have had a focus at Silverado for about the last 8 years of really trying to figure out what a behavioral expression is saying and presuming discomfort before we would use psychotropic medications to medicate away that behavior, whatever it's agitation or something along those lines. And I think this first case study, and we in that case have had many, many positive success stories, but we wanted to share 3 that I think will help bring home both the challenges and the opportunities as you work to advocate for your loved one or a resident or patient with dementia. And the first was a patient living with dementia who was on hospice, and she was yelling out always, "I want to die, I want to die." And when we investigated, the hospice nurse was very hesitant to add a consistent routine, or what we would call scheduled, stronger pain medicine, because she said, no, the family doesn't want her sedated. And if I started giving her morphine routinely, the family would be afraid she'd be too sedated. But then when we looked at the medications the patient was currently on, she was already getting several psychotropic medications that were very sedating, and it was all being given for her behavior of yelling out. And she did have an analgesic medication. So she did have a pain medication that was ordered, but it was ordered on an as needed, or what we call a PRN basis. But nurses weren't thinking about giving it. And that's because in general, nurses are, and I say this as a nurse, we're trained to think pain is something that something hurts, you give pain medicine, and then you say, yes, it's effective. But for just a behavior of yelling out or resisting care or agitation, most providers do not think about that as possibly being pain. In fact, that's why we have changed to calling pain presuming discomfort, because pain is a really hard word for people to see behaviors as pain, but you can always ask the question of, does that person look comfortable? So for this particular lady, when we offered her pain medicine, she yelled back, "I am not in pain." But then when we said, well, then why are you yelling out? And she said, "I hurt all over." And so that is a perfect demonstration of the kind of aphasia and word finding difficulty. And as Aaron said earlier, the word salads that can appear in dementia that really make it difficult for people to identify what they're feeling. So on that particular patient, we actually tapered her off of the sedating psychotropic medications that she was on, and we started giving her stable doses consistently of pain medication. And for the next 3 months, while she was still on hospice, she lived a very comfortable life, no longer cried out, and was able to interact with her family again, which she had not been able to do before because she was always yelling out, "I want to die, I want to die." Next case study. Let us tell you about Marvin. So he had frontotemporal lobe dementia, And he had behaviors like booming voice and striking out and grinding teeth. And boy, he was very combative with ADL care. And he was on hospice and was very disruptive. And if you looked at him, he didn't appear to be comfortable. But he had oxycodone because he was on hospice, ordered on a PRN or as needed basis, but no one gave it to him because he wasn't complaining of pain. But he was on lots of antipsychotropic medications, including PRN or as needed Seroquel. And, and sometimes he'd respond to meds and sometimes not. And, and family members, again, many family members often worry about lethargy or sedation. And currently in our society, we're very worried about pain medication. And I would just remind people that the psychotropic medications, the antipsychotics and the other medications are also very sedating. But in this particular patient, we were able to reduce his pain medicines and then titrate down the sedating antipsychotic meds. And he again was comfortable for several months and once again was able to interact with his family member, which he was not able to do prior. So these are the kind of things that if you think about, well, anyone with a dementia will become combative or anyone with dementia will cry out or be disruptive. We would ask, and what we have really learned is absolutely presume that that is discomfort before you think about medicating away the behavior. And then finally, the last patient we want to share with you is LK. And she's only 73 years old, but she did need total assistance with care. Her diagnoses were nothing specific about pain. They were dementia, insomnia, seizures. She had psoriasis, hypertension, had UTIs in the past, and hyperlipidemia. And all she was on was Depakote or an anti-seizure medicine at a low dose. But her behaviors we saw where she would pace all day. She actually kicked out a window in the door and she would push and hit, and redirection didn't help. And interestingly, her behaviors always worsened later in the day. And so it would have been easy to assume, well, that's just sundowning, right? Because we know that people living with dementia often later in the day can get sundowning types of behavior. But so the question you want to ask is her behavior just her dementia or sundowning? So when the team asked themselves, as she was doing this pressure pacing around the community, they really said, does she look comfortable? And they answered it, no, she does not. We don't know what's going on, but for sure she is not. So they started her on a routine medication saying maybe she has a neuropathy in her feet and that's why she's pacing all the time. They didn't have anything to show that, no test or anything to prove it. But this low dose of the medication for neuropathy actually stopped her pressured pacing. She was able to sit and actually engage again because often the discomfort is so bad. People are up and down and walking. And as Erin has shared, being able to enjoy engaging with others. And she actually, while she continued on this very low dose of medicine for her neuropathy, she became a very active member of our Ladies Red Hat Society. And you never in a million years would have guessed that she was who had kicked out the window with discomfort. So finally, we would just ask that the best way all of you, and I would say, could advocate for someone that you are either caring for or love who is living with a dementia that has a behavioral expression such as pacing, resisting care, becoming combative with care, yelling out, or any type of agitation or aggression. Before you ask your provider for medicines like an antipsychotic, things like Seroquel and those kind of medicines to take away their behavioral expression, ask yourself, is it possible that that behavioral expression means something? What are they communicating? And is it possible that if I presume it could be some type of discomfort and gave a routine 2 weeks of something as a routine pain medication to see if it responded to pain medicine before I went to the medications such as antipsychotics, you could really significantly improve your loved one or your patient or resident's quality of life. So we'll stop there.
Back to you, Kim. Thank you.
Okay, I'm here. Oh my gosh, that was such a fabulous and much needed presentation on a very important, very valuable topic. So we are so appreciative of Erin and Kim being our guests today. This is your opportunity as the audience to ask questions. So if you have a question for either Kim or Erin, be sure and type that into the chat right now in your toolbar. Also, before we get to that, a couple of things I want to take care of. One is I just want to remind everyone of the importance of being aware of any implicit biases or just unconscious stereotypes as we care for others. So a best practice is a person-centered approach. That's certainly what Erin and Kim were talking about today, where we really view each person that we care for as an individual with unique needs and preferences and treat them with dignity and respect, even when they're different than ourselves. And I know everyone believes this who's online with us today, but it's just important to remember that we always have to listen carefully and respectfully so that we can really understand our patients' unique perspectives and preferences. And in that way, we're able to build trust and provide just the absolute highest quality of care. So the other thing I wanted to do before questions is I just want to take a minute to thank our sponsors once again. You're looking at them on the screen. They are our faithful month after month sponsors for this wonderful series. O'Connor Mortuary, Care Choices, Hospice and Palliative Services, Caring Companions at Home, and Alzheimer's Orange County. Also, everybody, please take note of next month's topic and date. Save the date of Tuesday, August 8th for managing loss of appetite in older adults, another critical issue. And we have, actually, we have someone coming from Rush University, Kristen Gustashaw. And she has a master's degree in clinical nutrition and a BS in food science and human nutrition and dietetics. So, and as I mentioned, a faculty member at Rush University. So yet another fabulous speaker and very interesting, valuable topic. Also keep in mind that we are going to, at the end of the webinar, release an evaluation as we close it out. If we should run over the 60 minutes, we understand that some people may need to leave, but do know that you can't get your CE unless you're here for the full program. So, okay. So I think that's all the business that I wanted to talk about before we open the question box. So let's see what we have for our speakers. So, okay, someone is writing about a PPA patient that they have, someone with primary progressive aphasia. So it's expressive as well as the inability to comprehend spoken and written language and no history of pain other than mild arthritis of the thumbs, which is now well relieved by turmeric. So how does a family identify, in this case, that a behavior is pain-driven when the behavioral expression is not more obvious? Good question.
Well, I'm going to give an opinion as a provider because I will tell you, as a 45-year gerontological nurse practitioner who had many patients with dementia and all of the different types, to your point, like PPA, you know, it's very hard because of the loss of cortical cells in various and all of the dementias and the difficulty with interpreting symptoms and expressing what those symptoms are. My answer would always be, what is wrong with presuming discomfort before you medicate away agitation? So it's too hard to prove discomfort. So what I always, when I teach providers, I always talk about, for 1 week, give me scheduled pain medicine. It's not going to be forever. We're talking someone moderately impaired. They are not going to become addicted. And either it will make a difference in the agitation or it will not. And I will tell you, probably 80% of the time, it makes a difference in the agitation, and about 20% of the time. And if you think about it, and that's why this is truly shifting the paradigm, because our paradigm as a society has gone to, even you heard Erin talk about the degree of pain and discomfort in the last 18 months of life out of Susan Mitchell's study. It was a seminal study about hospice services in 2009, showed that people have the degree of discomfort as someone with terminal cancer. So I would say, even if it's just Tylenol, round the clock for a week, and just watch to see if there's any improvement. It might not resolve it, but if there's any improvement, and if there's a little improvement, but not enough, try going to a little something stronger. So, to try analgesic before you go to any psychotropic. Everyone is well aware of the black box warnings and what psychotropic antipsychotics have. And yet it feels to me as a provider often that we go first to something to medicate away that has side effects, just like pain treatment, and try to prove pain. And I would say, how about if you presume discomfort before you use the side effects present to antipsychotics? So that's my perspective.
That sounds wonderful. So just presume pain and treat it for pain first. For how long, Kim?
You'll see a difference in a week. This doesn't
Okay.
happen. You can negotiate with your provider and ask for a week. Can we just try it? Because something seems wrong. And I will just share, I had a patient in my clinical practice who became very delusional and agitated and horribly. We were using every antipsychotic in the world, couldn't figure out what her behavior was. And she died after about a year of that kind of behavior, and stays in geropsych, and all her labs were normal, no urine infection. And it ended up, the family couldn't figure out what had happened. They did an autopsy, and her bones were riddled with bone cancer, because she had cured breast cancer 25 years previously that no one had even considered. So, it can be very difficult to prove pain.
Absolutely. Is there anything you want to add, Erin, or do you feel like that's way sufficient, right?
That's great. Yes.
Okay, thank you. And Kim, we do in our trainings, our family caregiver trainings about behavior, we do to ask them to think medical first. Think pain, think some kind of medical condition, or maybe just some physical thing, like anything from a rock in their shoe or tight-fitting clothing. To think about physical discomfort or pain. So we'll continue to reinforce that. Let's see what's next. Do we really need medication to sedate people with dementia?
Well, I don't think the point of, the presentation was to make it sound like anyone's being sedated. It's really a comfort-based factor. We don't want them sedated. That means there's something too much there. But like the story that we shared, another story I share with families that come in is, let's say you have somebody and they have really bad allergies, and you take them to the doctor, and the allergist says to that person, well, just stop reacting. Tell your body stop reacting to whatever you're allergic to, right? They can't do that. It's internal. It's not something they can help. So to leave them in that state of fear or anxiety or discomfort and not help them is really not providing them a great quality of life.
That's right.
And I would also add that sometimes what we see when people move in and may have been at home or somewhere else, they're actually using other medicines to sedate to keep people safe for the behavior. Yeah. And so at least our experience has been that many times those sedating psychiatric meds might not be as needed if you really are addressing the source of possible discomfort.
Thank you. Just a comment that I want to share with you as presenters is that one of our attendees is giving you a great rating for your presentation. She said it's excellent and she will use it in her care center in India. So she's online with us from India. Next question. Do you believe most trained geriatric RNs know that behavioral patterns may be related to pain? So they address the sources of pain and not try first to alter the behavior? Do you think most geriatric RNs know this? Maybe I shouldn't have Kim answer this. Maybe I should ask Karen to answer it.
And well, let me just say, I will tell you, we teach this to all of our new providers. Anytime we get a new medical director at Silverado, we share this with them, that we want to make sure they understand it. So I think there's a real need for the education. I'll answer.
So it may not be part of their original training, right? And we need to change. We need to advocate for that. Right. Yeah.
And I'll say, remember, right now we live in a society deathly afraid of pain treatment, right?
Yes.
And the controlled substances have gotten a little nuts with how it's been abused. And so, you do have to kind of advocate for people who may be within 18 months of end of life. That's a different situation than others.
Yeah. And we need to get over this foolish conviction about addiction and everything else, and just make sure that people are given what's needed to make them comfortable so that they can have that quality of life. How long should you wait before you think a pain is genuine, or is it just that they slept wrong or something similar to that?
I would always use the question of, when are you at a point of thinking of another medication for it? When are you going to ask the doctor for some Seroquel or Ativan? I would say before you do that, why don't you consider that it's possible it's discomfort rather than some other behavior that needs to be medicated away?
Yeah, I would say if it's affecting their quality of life, even if they're just at home, relaxing, if they're not able to enjoy their usual, very minimal routine, again, do they look comfortable? If it's a no, then would we want to leave ourselves uncomfortable like that? Probably not.
And I think it's important to clarify, we're not saying someone necessarily needs pain meds all the time. Do it, as we talk often at Silverado, about a trial. Try it at a week, see if it makes a difference. If it doesn't stop, then consider if it needs a psychiatric medication or a stronger pain medicine. So that's what you want to be able to work with your provider around.
Okay, the next one is a little bit off topic, but someone is asking about the use of the term demented. Because I think one of you referred to someone as demented. Is that term acceptable?
Well, if I accidentally said it, I apologize. We would usually say that someone is living with a dementia, so that was not an appropriate word to say. I thought I saw in the chat that someone had asked the question about what is dyspnea. And
yeah, that's another question. Yeah, we can do that one.
If I did say that, is I apologize. That is nothing. We would say they're living with a dementia.
You shouldn't apologize. I mean, that is a term we have been using in the field for a long time, but we're shifting away from it. In the DSM, we're now referring, instead of dementia, we're referring to this collection of illnesses as major neurocognitive disorders. But, we all have to take time and transition our language, because I admit I don't readily use that yet. So, yeah. And so go ahead and answer that question about now I've forgotten how to pronounce it, Kim.
Oh, it was just dyspnea, which is shortness of breath. Difficulty breathing is what that is referring to.
Okay,
and that's what was on the slide about end of life in that last 18 months of life.
Okay, thank you, Kim, for clarifying. Can pain also trigger past traumas that the patient has been through, caused by things such as abuse, DV? What's DV? I don't know what that is.
Well, I will tell you, in our experience, rather than pain doing that way, we would say those traumas and PTSD can often cause behaviors, right? And so when you're working with your provider, they may think of a different kind of treatment more for possible PTSD type symptoms rather than medicating it away. So that's the way you would individualize care for that person.
Okay, good.
Domestic violence.
Oh, domestic violence. Thank you, Kim. Thank you. All right. So PTSD situations, right? Okay. A comment, I had a patient with end-stage Parkinson's on hospice with contractures and was immobile and nonverbal after a nice sponge bath and a massage in his hands and legs. I watched him physically have less tension, saw a light in his eyes and him trying to smile. With these small changes, I could tell how he was previously in pain.
Beautiful.
Well done. How can an untrained family member convince a medical professional that the patient's agitated behavior may well be an expression of discomfort? And they're saying, yes, I'm agreeing. This was an excellent presentation. So yeah, so how can they reinforce this with a medical professional?
I would just, that's a really tricky one. I will tell you that I continue to have to advocate for sometimes with certain providers that are just absolutely not. And I would only say, you know, if you have the option to change a provider. The other thing is I encourage people to really negotiate. You're not saying you want a pain medicine forever, but you're saying I need a week to see if it's different. I will map their behavior. I will let you know if there's anything different and we'll come back in a week or call you. That's the kind of negotiation I would try.
Yeah, I was going to say behavior. I was going to say behavior mapping, because sometimes if they think it might just be once in a while, right? Like one time a month or twice a month. So if you can map it and say, hey, every day at 3 o'clock or whatever, or whatever is triggering it or causing that, that's at least more evidence to provide that. And like Kim said, if you can get a second opinion too.
I will say that there are some of the tools that that are out there to try to, and we have to do this for some providers that are more data driven. So there's a test actually called the MOBID-2, and there's also the Pain AD. And the MOBID-2 is one where you just put a person's through full range of motion in all their weight bearing joints. So you raise their arm, you know, put their leg, and often it can elicit discomfort. And so if someone has pretty moderate arthritis, you'll get a positive MOBID-2. And so that can help you talk to your provider.
Excellent. Good to know about those tools. Here's a great question. Considering the client's, well, they're all great questions. I should qualify that. Considering the client's cultural background, have you seen differences depending on the culture to their response to pain? And are there ways we can be more culturally sensitive with our clients?
That's a tough one. And I would say, yes, we do see that quite often, not only cultural background, but educational level as well. Cultures that sometimes are more predominantly patriarchy versus matriarchy, not saying one of them over the other, but yes, it is very common. And sometimes, you know, if we have perhaps a healthcare provider who's been providing that level of care to somebody and they become cognitively impaired themselves, it's hard for that family to get past that. I think most cultures, if not all, have some sort of peace component, comfort component, whether it's spiritual or relaxation based. And I think starting to work on it from that angle, you know, does dad seem like he's experiencing this? Does he seem like he's at peace today? Does he, you know, I think that would probably help, because that's really deeply rooted in the culture itself.
And using some of those cultural practices, right?
Mm-hmm.
I would think. There was something else I wanted to ask Kim, but now it slipped my mind. So we'll just move on. Oh, I wanted to comment. What about, you know, say you have a culture where people are really conditioned to not want to complain. So the patient themselves are pushing through the pain. I mean, that might be a consideration in certain cultures as well, right?
Mm-hmm.
Okay.
That's when we look for the nonverbal cues that we mentioned too, because those are hard to mask. A little grimace here and there, and families will know, even they've been with them a long time. You will know more so even than healthcare providers if that's an actual grimace, or if, like, your mom raising her eyebrows, does she do that when she's in pain? That's not a very common one that you might think of that might be pain related.
And if you remember, the strongest point we can really make with this is just don't presume that agitation or any of those kind of behaviors that can occur, pressured pacing, are due to the dementia.
Mhm.
That's regardless, yes, someone from a different culture may find that, a different type of support or healing or meditation is helpful or might demonstrate it better. But the biggest gift you can give to your clients or your patients or your loved one is to not make the assumption that they're only agitated because of their dementia.
Correct. Okay. We are running over time now, but as long as you ladies are willing to stay on for another few minutes, we'll do a few more questions, if that's okay. What are some examples of pain medications, and would you comment on the use of CBD for anxiety and agitation?
I'm going to take the easy part first, which is the CBD and THC. I will tell you that we at Silverado find therapeutic medicinal cannabis incredibly helpful, not just for the discomfort, but for the anxiety, I had one provider tell me there's no such thing as being, quote, too mellow. Which was an interesting perspective, but I would just say, so, work with your provider on using medicinal cannabis. Lots of people don't have as much against cannabis as they do against pain medications. I would say in terms of the other questions, and as a provider in the past, I'm not currently a provider, so none of this is recommendations, but I would say that we will sometimes talk to the provider about starting with Tylenol, and after a week, if that does a little but not much, we might go to medications like gabapentin for possible nerve pain. We might go to, if we think it's things like muscle cramps in Parkinson's, we might ask for an order for something like naproxen that's very effective. And many of you who may have someone earlier in a Parkinson's, living with Parkinson's, may tell you that they often will take like some naproxen on a regular basis. So that's one medication. And then if we continue to see mild improvements, but not much, we might ask for really some kind of an opiate for a short time and see that different schedule. So something like the medications that people really resist. But these days, most of the providers really need justification to give someone an opiate. So that's where you want to come in and say, whenever we get her dressed and lift her arm, we see that she grimaces and then she hits out at the caregiver. That's the kind of thing where we think, oh, she's got a bad shoulder or something, and so those are the specific helpful things you can do for your provider to provide you a stronger analgesic.
Great. Someone's making a comment. Talk or other non-medical therapy would be of help to pain relieved more than half of patients without physiological intervention, in my experience. Did that make sense? Should I read that again?
Not to me.
I'm not following it exactly. Talk or other non-medical therapy could be helpful for pain relief. And it looks like they were comparing that to people that had some kind of physiological intervention.
Absolutely. We would
Got
say
it.
appropriate engagements. We would say, we talk at Silverado that we have a lot in our model of care in terms of things like engagement and purposeful living and connection and with others. And so, yes, that absolutely is an important piece. We are not saying medications are the only treatment.
Great. And when one more question, when medications are used, how often should they be assessed for the effectiveness of the dosage or whatever?
Depends on the medicine, how long it can last. If you're using something that maybe needs to be slowly titrated up, you might decide 3 weeks. I think most providers might like a report in a week. Did it make a difference? And then kind of, see you at your regular visit. So you'll have to figure that out with the type of medicine you're using in your provider.
Okay. All right. I think that we need to end. This has just been wonderful. Thank you both so much for sharing your time and expertise with us. And everyone, will be closing the webinar in just a second. And as we do, wait a second. It takes just a few seconds for the evaluation to pop up and complete that. And again, keep in mind our next webinar, Managing Loss of Appetite in Older Adults, on Tuesday, August 8th 8th. And as always, if you're interested in learning more about some of our educational events and other services and available, you can go to our website, www.alzoc.org. All right. Thank you, everyone, and have a great day.